Good evening, students. So this is the second class on white matter of cerebrum. So in earlier class we have finished with association fibers and commissural fibers, and now we'll be dealing with the projection fibers. These projection fibers are having afferent and efferent fibers passing to and from the brainstem and spinal cord to the entire cerebral cortex. So mainly pass within internal capsule between caudate nucleus and thalamus medially and lentiform nucleus laterally. The fibers radiate to cortical areas as corona radiata. You can see here, this will be the internal capsule, this is the corona radiata, and these are the projection fibers, long distance projection from cerebral cortex to the lower centers and from lower centers to the cerebral cortex. So these were the commissural fibers, these are the association fibers, and these are the projection fibers. You can see here, so a Campart band of neocortical projection fibers, main highway for input and output from cerebral cortex. So continues above as corona radiata and below as crus cerebri. So the most important point is this crucial point, which is called as internal capsule. So above this, these fibers diverge as the corona radiata. Below this, they continue as the crus cerebri. So here there is lot of compact arrangement of sensory and motor fibers, which is a part of projection fibers. So it is V-shaped in horizontal section with concavity laterally. So now we'll be dealing ahead with internal capsule. So internal capsule have 5 regions. Anterior limb is the portion between the lentiform nucleus and head of caudate nucleus. You can see here, this is the head of caudate nucleus and this is the lentiform nucleus. This is the anterior limb. Posterior limb is the portion between the lentiform nucleus and the thalamus. So this is the posterior limb, which is between the lentiform nucleus and thalamus. And the bend between anterior limb and posterior limb is called as the genu. And this part of the internal capsule, which is behind the lentiform nucleus, is called as retrolentiform part. And there is some part below the lentiform nucleus that is called as sublentiform part. You can see here the genu is the portion of the junction of anterior limb and posterior limb. The retrolenticular part is a portion posterior to the lenticular nucleus, whereas sublenticular part is the portion inferior to the lenticular nucleus. So anterior limb, genu, posterior limb, retrolentiform part, and sublentiform part is not seen here. This is the lentiform nucleus. So in which the inner part is the globus pallidus, outer part is the putamen. This is the head of the caudate nucleus, and this is the thalamus. So now let us see the motor fibers which are passing through the internal capsule. So through the anterior limb, you can see there are frontopontine fibers. Even these frontopontine fibers pass through the genu as well as the posterior limb, whereas paretopontine and occipitopontine fibers pass through the retrolentiform part, and the temporopontine fibers pass through the sublentiform part. And here if you see the corticonuclear fibers, that means from cerebral cortex to the cranial nerve nuclei in the brainstem, so those fibers are in the genu, whereas corticospinal fibers from cerebral cortex to the spinal cord are in the posterior limb in this order, like anteriorly there are fibers to upper limb, then trunk, then lower limb, and then the extrapyramidal fibers, corticorubral tract and all those things are present in the posterior limb of the internal capsule. These are the distribution of motor fibers through the internal capsule. Now let us see the sensory distribution. You can see here, this is the superior thalamic radiation, this is the anterior thalamic radiation, this is the posterior thalamic radiation, this is the inferior thalamic radiation. Inferior thalamic radiation is nothing but the auditory radiation connecting medial geniculate body to the primary auditory area, and posterior thalamic radiation is nothing but the visual radiation or optic radiation connecting lateral geniculate body to the primary visual area, geniculocalcarine tract. So now you can see here through the anterior limb, you can see there is anterior thalamic radiation which connects the dorsomedial nucleus and anterior nucleus of thalamus to the frontal lobe, and here through the genu and posterior limb. So here you can see this is through the genu and posterior limb there is superior thalamic radiation. Through the retrolentiform part there is posterior thalamic radiation, and through the sublentiform part there will be inferior thalamic radiation. You can see here there is the posterior thalamic radiation from lateral geniculate body to the visual cortex, geniculocalcarine tract or optic radiation, and this is a medial geniculate body. Through the sublentiform part it is going to the primary artery area, artery radiation, otherwise the inferior thalamic radiation. So now the blood supply, if you see, so there is one recurrent branch arising from the anterior cerebral artery, that is called as recurrent artery of Hubner. Recurrent artery of Hubner. So then you can see this is the middle cerebral artery. You can see the straight branches supplying the posterior limb, and you can see few direct branches coming from the internal carotid artery also supplying the genu. And here you can see this is the anterior choroidal artery which is supplying the sublentiform part, and you can see posterolateral central branches from posterior cerebral artery supplying the retrolentiform part and sublentiform part. So internal capsule is receiving branches from anterior cerebral artery, middle cerebral artery, internal carotid artery, anterior choroidal artery, and also from posterior cerebral artery. Few branches might also come from posterior communicating artery. So any of this branch might get injured. That means like it might rupture or it might get blocked, leading to the infarction of this internal capsule. So where large number of fibers will be involved. So you can see what are the things which are happening here. So if there is lesion in the cortex, there will be contralateral hemiplegia. So aphasia if lesion is in dominant hemisphere. If there is lesion at the internal capsule, there will be contralateral hemiplegia and ipsilateral EMN type of facial palsy. If the lesion is in midbrain or crus cerebri, so contralateral hemiplegia, ipsilateral element type of third nerve palsy. So if it is in pons, again contralateral hemiplegia, ipsilateral element type of sixth and seventh palsy. If it is in medulla, again contralateral hemiplegia, ipsilateral element type of tongue paralysis. So spinal cord, contralateral hemiplegia, no cranial nerve involved because no cranial nerve nuclei are present in spinal cord. So always if you see everywhere it is contralateral, contralateral, contralateral. It indicates that the left cerebral hemisphere controls the right half of the body, whereas the right cerebral hemisphere controls the left half of the body. And if you see here, up to internal capsule, it is human type of facial palsy because upper motor neuron. But when it comes to midbrain, they have given ipsilateral element type because midbrain has the nucleus of third nerve. So the upper motor neuron has already come and relayed in the oculomotor nuclei. So here oculomotor nuclei itself damaged. So it is element. Again here also pons contains 6th and 7th cranial nerve nucleus. So again element type. And medulla contains the 12th nerve nuclei. So again element type. So if it is higher than the midbrain, then it becomes a human type. If it is starting from midbrain, depending on the which nerve nuclei are present in that particular region, it will be LMN or UMN. Suppose if the lesion is in midbrain, then it will be a human type of facial palsy. But at the same time, if lesion is in pons, then it will be element type of facial nerve palsy. Thank you.